Dear all, welcome to the UP ISAR TOG live stream, and the topic is tricky situations and solutions in infertility. We have a galaxy of stars, so let me first welcome Dr. Seema Pandey, who is the moderator for this program. She is the President, Azamgarh OBGYN Society, National Executive Committee member, ISAR. Welcome, Dr. Seema, and thank you for being part of this. I hand over the con to you, madam. Please continue the proceedings.
At the outset, respected Secretary ISAR and our guest of honor, Dr. Kedar Kanla, our chairperson, Dr. Anupam Gupta, UP ISAR, our vice chairperson, Dr. Neelam Modi, UP ISAR, our UP ISAR secretary, Dr. Rakhi Singh, my distinguished faculty and dear friends who all are watching from all around, I welcome you all to first ever academic webinar of UPSR Tricky Situations and Solutions, and we are expecting to solve few such problems together. Welcome you all. And now with this, I would just start our first case. So our first presenter is Dr. Monica Sisdev Shukla. She is going to present a case and then discussion will be followed. May I have the CV of Dr. Monica, please? Monica is an IVF specialist from Kanpur, and she is an academic girl, and she is going to present the case now. Over to you, Monica.
Yeah, I'll then just sharing my screen. Just a second. Yeah, it's here. So good evening, friends, respected seniors. So, I think I'm audible to you all. Yeah. So this is a case of a 32-year-old fertile female with normal HSG.
Monica, I just interrupt. Sorry, our UPSR chairperson, Dr. Anupam, has joined, and since he has very important work to do, I would welcome Dr. Anupam.
Thank you. Well, I think let's continue. Let Monica continue to give the case. Let Monica continue. I welcome all of you, and it's a pleasure seeing all the faces after so much. Because of this lockdown, we've not been able to meet in the real world. So it's a pleasure having all of you in the virtual world. Nice to see you all. Let's start. Monica, you can continue your case.
Okay. Thank you, sir. Thank you, sir. So she is a 32-year-old female with normal HSG, AMH 3.6 nanogram, husband semen parameters absolutely normal, and she was given ovulation induction with clomiphene citrate 100 milligram once daily from the 3rd day to 7th day of her cycle. Her follicular monitoring was going on well, and she showed a 22 millimeter dominant follicle on day 14 with endometrial thickness as 7.5 millimeter triple line. She was given a shot of SCG 5000 IU intramuscular for rupture. Her subsequent scan showed the figure is in front of you guys, and it was as expected luteinized unruptured follicle. So this is a very common scenario which we face in our day-to-day practice, especially when we are doing some ovulation inductions and IUI cycles. My next concern is that may I know the diagnosis? We all know it is clear. Yeah. How should we proceed now? Ma'am, our respected seniors, you can discuss it out.
Yeah. So, you are muted. Seema, you are muted.
Yeah, I was requesting Monica to just stop sharing her screen so that we can see.
I'll stop it. Yeah. Done.
Yes, now you can ask the question.
My first question is, how should we proceed with the case? We have seen the figure, it is luteinized unruptured follicle.
Yeah, if I were to give my opinion, I mean, this cycle, I don't think so you can achieve anything much in this cycle. Mm-hmm. She is unlikely to be pregnant with this scenario that you have shown us, because normally unruptured luteinized follicle, they don't give you a good pregnancy rate, because actually there is some it's an ovulatory dysfunction. So this cycle we cannot do anything, probably give her luteal phase support just to ward over this cycle, and then from next cycle, if you were to take my opinion, I would probably stimulate her with gonadotrophins.
Okay, that is your view. Basically, I had a question with our faculty. Does real luteinized unruptured follicle exist?
Yes, it does.
Yes, at times it is there, and if we are not giving the trigger at the right time also matters a lot. The trigger ideally should be given at the right time. That also matters, and apart from that, the luteal phase, if we need to be watching on our menstrual cycle, how long is our menstrual cycle, and whether it is a short menstrual cycle or a very long menstrual cycle, that will also to a certain extent define upon the luteal phase insufficiency. And if suppose this patient has been having a very short cycles of about say about 21 days cycle, then probably 20 days she may be having some amount of luteal phase insufficiency.
And there could be other reasons also for this LUF. There could be endometriosis. There could be a background of endometriosis. She could be a patient having recurrent PID. Maybe she has some inflammation out there. And so we have to rule out the other very common causes of LUF actually.
Dr. Neelam, I would just like to...
Yeah, I couldn't hear the case because the voice was not coming. But as in the case of LUF, so it does exist, though not very much, but there are many causes. Dr. Anshu just enumerated those. So in this, what you want to ask, how to proceed? So in this cycle, we cannot proceed, means we are not going to get anything.
Pregnancy, yeah.
So it was stimulated by clomiphene, I think.
Yeah.
Next time we can try
With
letrozole. If we are, it depends on the age of the patient and how long infertility is there, and whether we want to try with the oral ovulagens or we want to go away straight to the gonadotropin. So next time, depending on these issues, I can try the letrozole or straight away gonadotropins.
So, Dr. Kedar, for the audience benefits, I just wanted to know, how are you going to confirm whether this patient is really having luteinized unruptured follicle, or in simple terms, how do we diagnose it? In this cycle or in the next cycle?
Good evening and thank you. Welcome for inviting me here. The picture which was shown is more of a corpus luteum hemorrhage rather than luteinized unruptured follicle, which I felt. Secondly, if at all one has to confirm, maybe post SCG injection on the 7th day, one can do a serum progesterone levels, and if the serum progesterone levels are less than 1.5, then I would strongly suspect that this is luteinized unruptured follicle or unluteinized unruptured follicle. And maybe in clomiphene citrate cycles, this phenomena is little more commonly seen.
Yeah.
If the cycle fails, I will do a scan and look. If this retention cyst persists, I will give her a break of one cycle, which will wash out the clomiphene citrate, and the cyst would disappear. And in subsequent cycle, I would try with letrozole. Letrozole has some papers talking about on luteinized unruptured follicle comparison with CC, and they found that letrozole has a lesser percentage of patients having luteinized unruptured follicle. Nevertheless, I would also give her empirical antioxidant therapy. Okay. And third thing would be normally I would do one cycle prior, which is called as natural cycle monitoring. And in the natural cycle monitoring, also if I see this unruptured luteinized follicle, means likelihood that her cause of infertility is going to be this. So then I would start evaluating, like Dr. Anshu Jindal and Neelam Mohani, that look at the endometriosis, infection, or some kind of oxidative stress which is present, which is interfering with the ovulation process, and take it from there.
How long will you give the antioxidants, Dr. Kedar?
Normally for 3 months, because one ovulatory cycle, like a spermatogenetic cycle, it will be for 74 days. So
you will like to wait. You will like to wait for 3 months and not go ahead with a gonadotropin cycle in the next cycle if there is no persistent hemorrhagic cyst.
My choice would be first letrozole rather than jumping for gonadotropin immediately.
So here comes the next question, which most of the gynecologists we are thinking about. Whenever we are seeing either a residual follicle or a luteinized unruptured follicle, the most important thing which comes to our mind is let's keep her on oral contraceptive pills. So what is your view? What is the view of experts whether these patients should be kept on OC pills or not?
That depends on what the patient wants. If the patient is if he's very right in saying that we have to confirm that there should not be any persistent follicle in the next cycle. And if there is none, and if the patient is keen for conceiving, she doesn't want to wait, then maybe, as I said, I would go for gonadotropins. Letrozole is also an option, but even with letrozole, you can have LUF. So gonadotropin, according to me, is a better answer, but that we are not debating on that this is better, that is better, but that depends on the patient. And if the patient is very cool about it, that I can wait, then definitely OC pills can be given to these patients.
Actually, OCPs will not treat that residual cyst, and it can prevent further cysts. So wasting time by giving OCPs to infertile patient is not choice for me.
So here comes my next question. Basically, there is no endocrinological basis on which OC pills they resolve residual cyst. They just take their own time to go away. Although all the subtle anomalies can be probably sorted out with COCs, or it gives a gap. The second thing which I have encountered in most of the cycles is when we are using clomiphene citrate, the timing of the trigger, does it affect or does it help making luteinized unruptured follicle? And in next cycle, are you, even if you are going to use letrozole, are you going to change the strategy about your trigger?
Yes, I will like. Can you hear? Can you hear me?
Yes.
Yeah, I would like to change the trigger policy. First of all, I will take the follicle should be around about 20 millimeter.
Yeah, and not 22.
I will add HMG plus HCG or HCG plus GnRH agonist for trigger.
Double trigger.
Yeah, double trigger. And what I also can do, I can do GCF also 24 hours before giving trigger.
Okay, that's an excellent point to add. And in all the practical things, when all these gynecologists, they are sending their follicular monitoring to a ultrasonologist, and the moment follicle size comes 18 to 20 mm, they are triggering it. Most likely that is not the right time. And here comes the role of either one of the natural cycle monitoring, and with CC and letrozole, whenever we are planning to trigger, if we don't have perifollicular blood flow monitoring and other assets, we can go to trigger when these follicles, they grow beyond 20 to 22 mm. That is the dictum, and next cycle trigger can be changed. SCG alone has been said to cause LUF, and sometimes SCG itself prevents the formation of LUF, and dual triggered is said to work. So basic strategy is just to flip the trigger. If you have been triggering at right time with SCG, next cycle you can go for agonist trigger, or if you were giving agonist trigger, then
one more point. If the patient is using already aspirin and all, we have to avoid that.
Exactly. That is very important point, especially those patients who are having rheumatoid arthritis or other kind of autoimmune diseases, and they're on long-term therapy with all these NSAIDs, and that is the real cause. Here comes the importance of history. So we have to rule out whether she any kind of painkiller or anything. So luteinized unruptured follicle, it does exist. Most of the time, wrong timing of trigger, wrong size, these are the things which make it commoner than it is expected to have. Dr. Monica, what are other questions do you have? And may I know how did you manage this case?
So basically in this case, what we did was in the next cycle, I stimulated with HMG and I gave an HCG trigger with 10,000 and we successfully had a rupture. Though the pregnancy was not there, but we successfully could have a rupture. The next question is, what are the types of LUF we have been discussing?
Yeah, one more thing. If we are giving HCG, what we can do, instead of giving urinary HCG, we can give combination.
More efficacious. It's more efficacious. Yeah.
And that's why we do always like one HCG only. If I give urinary HCG, I always use two brands. Two brands, not one brand. One brand of this company and one of from that company. If you are using urinary, otherwise combinant is the best.
Yeah.
Okay. Anything else?
So the basic question of what are the signs of ovulation, as we all know, in TVS ultrasound as well as LUF in TVS ultrasound, so that we as a gynecologist can differentiate between LUF and a mature follicle and rupture.
Yeah.
So one question that I found one point very interesting, introduction of GCSF. I would like someone from my panelists to throw some light. How are we going to use it? When do we use it? And how much and how?
1 ampule of GCF. Am I audible?
Yes, very clear.
Yeah. I give a GCF 20 to 24 hours before giving HCG.
Okay.
Normally, the GCF receptors are there in the granulosa cells. So, if we give this one GCF, this will give a cytokinin release, an inflammatory process. And this effect is a short time. But the neutrophils which it produce, this effect lasts for a long time. So, that inflammatory process will help to induce this ovulation. So it's a quite I just don't remember the study name, but it is well known study where they are giving the GCF and result is 1,000 times better than as compared to the simple HCG injection.
Since we are going to wind up this case, I would just like to know if Dr. Kedar, you want to add something more in LUF?
Maybe the first is the diagnosis to be confirmed, it's LUF. Second is the second cycle, when you look at the scan and if you find the cyst. Oral contraceptive pills may not be given because that gives a chance for the woman to ovulate and have her own pregnancy. Cyst will disappear on its own. Third cycle, in between I would start the oral antioxidants. Then look at the other signs of something which contributes to the luteinized and ruptured follicle. Third cycle, I would give letrozole and maybe I'll give a trigger. If I generally give SCG only 5,000 international units. I never give more than 5,000 international units and single brand. If at all, I may combine it with the Lupride as a dual trigger and try. If that also doesn't work, then the last approach should be gonadotropin with GCS. If that is what I am looking at, I would cover up this way.
But when we are giving Lupride for these cases, then we cannot go in for an IUI. Only thing is Lupride along with little amount of HCG would definitely help them up.
Okay, I said it's a dual trigger. So SCG 5,000 with 1 ml of Lupride would be sufficient.
Yeah,
I only want to add that LUF, if not treated, can recur. So
yes.
There's very high chances of recurrence if you don't look after it and don't treat it.
Yeah, and most of the time, this unruptured luteinized follicle, which recurs, the commonest cause is endometriosis.
Yeah, very true. Very
Yeah.
true. I would agree with that.
Rule of diagnostic laparoscopy, hysteroscopy, along with empirical therapy with cabergoline, as we do in endometriosis. So these are few things which don't have much evidence, but they do exist in the management.
Yes.
So with this, I think we have covered almost everything regarding LUF. Later on, when audience questions are there, we'll take it. Monica, can we proceed to the second case?
Yeah, sure.
Yeah. So here now I'm welcoming my youngest chairperson, YTP committee, young and dynamic, beautiful, chirpy Dr. Niharika Malhotra, who's going to present the second case. Welcome, Niharika.
Thank you, ma'am. Thank you, everyone. And it's been a great pleasure to be with you all here. And I'm going to share a very interesting case today, and really a case of misdiagnosis which can happen. So I think I hope you can see my screen now.
Yeah, we can.
Yes.
So this is my case, and as you can see, she is a 32-year-old female who presented primary infertility, married for 4.5 years with regular menstrual cycles, and she came to a doctor in view of infertility in August 2018, where an investigations were done. She was advised a semen analysis and an HSG. So her husband normal, and her HSG showed a right tube opacified, small cavity, and query left tube not visualized, query unicornate uterus. So I've put the HSG picture here, and my first question will be here. I've not finished my case yet. That what do you think actually went wrong, and can you somebody opine regarding this HSG here? Ma'am, we can't hear you.
It looks like a unicornate uterus on an HSG, and with you can see the right tube is opacified, but the left tube cannot be seen. So prima facie, it looks like a unicornate uterus with the right patent tube.
Yeah. So she went to this doctor, and they did her HSG, and then they sent her to another doctor. So she went to another doctor, and they advised her an ultrasound. So the ultrasound came up with a report of uterus diadelphus with left horn well developed, right horn small in size, and both endometrial cavities normal. Her AMH was 3, and this doctor gave her 2 to 3 cycles of ovulation induction with timed intercourse with clomiphene in November and December 2018. And then she was left alone. So after all this, in December 2019, she came to us. What actually the doctors here missed was none of these doctors did a per speculum examination. So that was what I first wanted to emphasize was ki, the first day she went to the doctor, they just did her HSG and her semen analysis. The second doctor did her just an ultrasound. And then when she was finally came to us, she was diagnosed with the complete uterine septum, vaginal septum with duplicate cervix and double vagina. And she was planned for a lap hysteroscopy, which was done at the end of December 2019. So my second question was that should an ultrasound be done before an HSG, because we already missed the diagnosis because we didn't do a per speculum. And would a 3D ultrasound or an MRI should be done in all routine cases where you suspect uterine anomalies?
The ultrasound needs to be done at the first go, and when the doctor had done the HSG person also should have written in that report.
Yeah.
HSG per speculum examination, without that it is not done. That doctor also missed it, or the radiologist also missed it at that center in writing it down that it was the septum in the vagina which was seen, or they missed it out totally and then did only directly doing an HSG and missed it out completely.
Yeah.
And ultrasound gives a great amount of information to us, and if suppose you add on if you have an advantage of doing a color Doppler, that is an added luxury to it. That would have given us a lot more information.
In your screen, please.
Ultrasound also gives a lot more information to us.
So, ma'am, but would you add a 3D ultrasound in all cases where you feel that there is a suspicion of uterine anomalies?
That gives a lot more information.
Yes. 3D ultrasound is a must.
Yes, we should.
We should do it for
screen.
But I don't understand how color Doppler, Rakhi, would make the picture better. How would a color Doppler help to give you more information in a Mullerian defect?
No, not the color Doppler, the 3D Doppler.
3D Doppler, yeah.
3D
ultrasound, yeah.
Ultrasound.
Can I add something?
Yes, Dr. Kedar.
Yeah. First of all, ultrasound to be done before HSG or HSG to be done before ultrasound. Both, if it is done before an operative laparoscopy, would add a lot of benefit for the patient.
Yes.
Say if you have done an ultrasound which shows bilateral hydrosalpinx, then one can counsel a patient for a clipping at the primary laparoscopy rather than secondary laparoscopy. So similarly here, what has happened is the radiologist has done the HSG. If it was the gynecologist who has done the HSG, would have definitely not missed this. Okay.
Yeah.
Secondly, Niharika, your father's favorite 2D ultrasound with sonohistography would be my favorite investigation rather than doing a 3D or MRI. Fourth, I will do an abdominal ultrasound to look at the Mullerian anomaly and renal anomaly. If the kidneys are, pelvic located and things like that, then I need to be little assured about what am I dealing with. So,
do you think 2D ultrasound with SSG is going to differentiate between a septum and uterus diadelphys?
Yes, 100%. Because if you see the fundus as one without the dip, it more or less tells you it's a septate uterus. In a bicornered uterus, there will be intervening the two horns. There will be a dip. So
but that will be clarified only on 3D ultrasound, Dr. Gedar, not on 2D.
Also get
2D will miss it. 2D is likely to miss it.
No, that time you have to do an abdominal ultrasound to see the dip. By 2D you can.
If you do a sonohistography simultaneously in both the cavities will be enhanced and you will be able to see both the sides going away from each other. Well, what you say, Anshu, is correct. If you do a 3D ultrasound, it will be much better in terms of counseling.
Yeah.
You can counsel the patient much better.
Yeah.
What you say is correct.
What I want to add, 2D sonosalpingography with normal saline is not a good choice as compared to oil contrast with hysteroscopy, HSG. And sonosalpingography cannot differentiate it clearly. Either you have to go for HSG or 3D ultrasound or
absolutely.
Seema, he is not saying about sonosalpingography. That's about sonohistography. So sonohistography can delineate the uterine malformation very clearly. And if you don't have luxury of 3D ultrasound with you, then definitely you can go for sonohistography. Because sonohistography for uterine cavity abnormalities, it is really very good. Combined with abdominal ultrasound, it will give a clear picture. Okay, how is the fundus?
Do you mean
that the best?
Sonohistography means you are using oil contrast with
normal saline.
Normal saline.
That is called sonosalpingography. Sonohistography, yeah, exactly. I am talking about.
Yeah.
And that is not a good idea for differentiating between bicornuate uterus, septate uterus as compared to HSG and 3D 4D ultrasound. That's what my point was.
Very true. Very true.
She's right.
I'm doing it every day.
It depends upon the experience of the personnel. If you are very well versed, then you can do it. If you are not very confident, then you send it for HSG. When HSG comes, you again send it for 3D ultrasound, confirm it, and then you decide. Rather than that, one Best thing is what you suspect, you send it for 3D ultrasound.
Yeah,
Matter is over.
that's true.
Why do HSG in between?
Then there is no facility for 3D, 4D ultrasound. HSG is better. I'll tell you the reason. SIS, we are doing the normal saline which we are putting, that does not stay there, and that's why that differentiation is not made that much. If you are expert doing TVS 2D, you can make it out.
As we diagnose polyps and intra-cavity,
those things we can diagnose better with CIS, but not these things.
Okay, 3D is the best, but if you don't have 3D in your hand, you can go for this. Some papers are there, some evidence is there that sonohistography can delineate uterine septum, but this is not the best.
Maybe I'm kind of, I think people who are senior enough, Rajul Tyagi, Neelam Mohri, who has spent 30-35 years, and putting an ultrasound probe inside, and they will be able to tell you there is something abnormal here. That is what the experience would talk about.
Yeah.
You know, maybe Anshu will also say.
Yeah.
Because I can say. So definitely these people are much more
2D, or even on 2D you can see two cavities.
Yes,
You can see two cavities so often, very often.
Just a transvaginal probe would prove us.
Yeah, transvaginal probe. You can see two cavities on.
Yeah.
True.
Yeah, Niharika.
So I'll share my screen again. So I wanted to do this case because it had a lot of points which I wanted to bring upon. So now this case is operated, and we did a removal of the vaginal septum by an harmonic scissor, and resectoscope was used for creating space for and the cervical and uterine septum, and hemostasis which is achieved, and we put a Foley's bulb in the cavity for a week. So the next question is on the basis, like, what do you think is the incidence of septums and infertility, and how these septums impact your infertility and pregnancy outcome?
Yeah. Incidence is around 10% of the patients it's the commonest Mullerian defect, and almost 10% of the patients can have a uterine septum as the cause for infertility. And how it causes is it constricts the space. The uterine cavity gets constricted. There is restriction of the space. It's an avascular structure, so anything that implants on it can cause implantation failure. And there is some problem with the receptors as well. There's deficiency of some hormonal receptors in this kind of septi. So they do contribute to infertility.
Recurrent abortions are also very common in these cases. Apart from that.
Very true, very true. Yeah.
Yeah. The malpresentation, growth retardation, premature rupture, so lot of complication of the antenatal complications are there.
If you take infertility and early abortions, then this septum's incidence is really very high. And if patient having the both.
So all of you do agree that whenever you see a septum, it must be operated.
Yes, there's a lot of controversy on this, but
no,
yes.
Not always. You have to see what type of septum.
What type of septum and how big is that horn already?
Yes.
If that horn is quite matured enough, then I think we can give them a trial. If the horn is not that matured enough, we need to create a cavity and the space.
But when a patient with septum, patient of infertility with a septum comes, then we always prefer to resect.
Because
especially with recurrent abortions, patient presents with recurrent abortions, you have to resect the septum.
But if the patient is having in 1/3 of the cavity the septum, so it is a grade C. According to ASRM, it is a grade C evidence that resecting the septum or not to resect it. But if it is in the more than 2/3, then we have to.
Dr. Kedar wants to say something.
What Dr. Tyagi said about, or Anshu said about septum being vascular, muscular, and fibrotic. So if the septum is fibrotic, then definitely it must be resected because your implantation is going to happen there with lack of blood flow. If it's a muscular septum, then more or less it would help.
Very difficult to differentiate, Dr. Kedar. How will you differentiate?
On ultrasound and a color Doppler. color Doppler, one will be able to, but it's a theoretical output.
Yeah, absolutely.
Secondly, telling a patient that see there is a septum, you try for conception, then you have an abortion, then we will do the cutting of the septum. So nobody is going to agree. So it's better that you tell them that your reproductive outcome is going to be not very good with the septum in. Better that if you get it cut, go for a second opinion if you want to. That is the best way. And come back if you wish to, and we can do the resection. I would put it up this way.
But thickness of the septum is not going to matter. In the ASRM guideline, thickness is not important. Sometimes you can consider the length of the septum is more important as compared to the thickness of the septum.
Agree, ma'am.
I think.
Excellent discussion is going on. From the audience point of view, I just want to know individual and practical view of all my panelists, one by one. What do you do when a patient of primary infertility comes to you and she has shown to have septate uterus? Do you cut it? You don't.
I cut it, and we do a hysteroscopic. We don't. We counsel the patient, but we cut it.
Believe everybody
Incise it
hysteroscopically, and how many of you believe in cutting the septum?
Incising the septum and not resecting it, just incising it. Yeah, we do that. Hysteroscopic resection.
Yes. What do you want to say?
I would like to counsel the patient at length and leave the patient decision on the patient whether they want to go in for a trial first, because at times these patients do conceive and move ahead, and at times if they are not going to conceive, and if suppose she is conceived and gone into an abortion, then I would like to go in for a hysteroscopic resection. Do give a trial, do give the option to the patient, let the patient decide how they want to go about with it.
But Rakhi, most of the time these patients, they come to us after many years of infertility to an infertility specialist.
If they are coming after many years of infertility and if they have had already abortions, then I would directly go in, explain them and go in for a resection of the septum hysteroscopically.
No, yes, Dr. Kedar, you were saying something, then I'll start.
I will say I will do a bias counseling.
Yeah.
It's very straightforward, saying that this is what it is, this is what is going to happen, and this is what it is, and if I do this, the best thing to happen to you is this. That's all. It's not like it's not very big thing to do, but I would do it a little bias counseling. That I can show.
Very good. Exactly. Let the patient decide in today's litigation scenario. Let the patient decide. Let them give the answers. Give all the pros and cons for both the situations. It's in their code.
Diplomatic. Be diplomatic.
So all said and done, all of us, if patient is of infertility or recurrent pregnancy loss, we are in that septum. That is a take-home message we want to give to the audience. Though there are multiple views regarding subfertility and septum, its size and shape and multiple things, but we don't want to go into all those confusing details, and we just want to give few important tips so that they can move ahead. Yes, Niharika, your next question, please.
Yes, ma'am. Okay, so now we've done what we've done. We've done a lap hysteroscopy. We've done resected the septum. And now my next question to all the experts is, would you leave this patient now for a natural conception? Any special advice you will give for this patient, because she was primary infertility, married for 4.5 years with normal semen parameters?
Niharika, before this question, one more question came to me. May I ask it?
Yes, ma'am.
Suppose you have resected this septum. Now again confusion comes. Whether this Foley's has to be there, whether this patient has to be kept on estradiol, or their IUCD has any role. Basically separation versus estradiol versus nothing. What is your day-to-day practice? Again, I would like to know each and everyone's view on this.
Yeah. I would like to say that there are two conditions. First is septum resection and other is Escherman or adhesiolysis. So in septum resection, I never put an IUCD or Foley's. For septum resection, I can give estradiol for 1 month or 2 months and then start fertility treatment.
So
and Follies and IUCD is for Ashermans or intrauterine adhesions, not for septum. Because I always think that they will increase the chance of infection. So
I think so. I agree with Dr. Neelam on this because I think they have very good healing, and within 6 to 8 weeks we get a good endometrial cavity after septum resection, and these patients can go for natural conceptions as well. So I also don't use an IUCD or any kind of a device there or a Foley's there in order to prevent adhesions. Yeah.
What about
especially if you are doing septum resection with the Caesar? It's okay, that there is no need. But if you are using the the monopolar current, then you may need this.
Even in those, Dr. Rajul, we don't need. We don't need.
I am doing with the septum.
Bipolar needle. Now nobody does it with monopolar.
Yes, we are doing with the bipolar or we are doing with the Caesar.
Oh, monopolar also gives very good results. We are doing with monopolar also, and we get we getting good results with that.
Monopolar.
I would like ideally, if I would have done, I would have put the patient on 1 month of Proginova at least. That is estrogen for at least for 1 month, and then asked her to try again.
So I would like all the panelists to speak one by one. Yes, Dr. Kedar, please speak.
It's a very tricky situation when you have a complete septum, because distension of cavity is going to be really difficult. Okay, so when you are cutting it, you need to be very careful. If you are a beginner, then I would suggest rather than overcutting, undercutting is much better. But if you are if you are good, you can see both the ostia at the same level as you have reached, then you can leave alone. Second, as Dr. Neelam Mori correctly said, in a case of Asherman's or a case of huge anterior submucous fibroid, you have resected, okay, and you are suspecting a intrauterine adhesion to be formed post-operatively, then only I would consider putting a Foley's catheter. Intrauterine copper T does not help in distending the cavity. And estrogen, 2 milligrams 3 times a day would be ideal. Call her after 7 to 10 days to see the lining of the uterus and with antibiotic coverage. And as Dr. Anshu Jindal said, you should leave her alone for 3 to 6 months. She will conceive and come back.
So my second question now, minimal duration of estradiol, and how long do you recommend this patient not to conceive?
2 months.
Do you not stop it at all?
2 months.
More than 2 months.
6 to 8 weeks.
That is around 2 months.
2 months,
So the whole panel is of opinion that at least 2 months abstinence from pregnancy should be there. And this patient, yes, please.
So if I have not cut the muscle,
okay,
I have just cut the septum, correct? I have not cut the muscle. Then why the rule of 2 months should come? My logic is, when you do a myomectomy, okay, you have taken the sutures.
Yes.
You give 3 months for healing, correct? Right? If you have done a cesarean, I understand. But here, my logic is only this thing. Okay, there is no need, but averagely we say, come back after, try after 2 months. If she conceived, don't abort her. That's
basically
ASR guideline. ASR guideline is 2 months.
So,
So
that is why
there is no contraindication.
why like parrots we are doing same.
For 2 months. Okay. So Niharika, do you have many more questions or something?
My last slide was this one. We'll just finish that. So this was my last question. So we've covered that managing post-septal resection, whether we want to do a Foley's or an estrogen. My last question was that do you think should we do a cerclage in the same sitting, or would you advise a cerclage to such patients?
Yeah, that is very important question. Yeah.
No, sir, not cerclage in the same sitting, I wouldn't say. Cerclage should be done when she gets pregnant, because I don't think so it should be done in the same sitting.
Any contraindication? Any reason why not?
Why do it in the first? I mean, you are making it more complicated. I think you should allow nature to take its take the case forward. And why should you apply a stitch there and interfere with nature? Let nature take its way. You've done your best for the patient, and now, like we just said, that she can even have a natural conception. And cerclage, when we will cross the bridges when we come to them. Why now? I don't think so.
So, Dr. Anshu, as we remember in the our PG days, we have been told that all those uteri with Mullerian anomalies,
Yeah.
they have preterm labor, and whenever they are getting pregnant. Many people believe in putting cerclage after pregnancy. Isn't it better that we do it as an enteral cerclage before pregnancy? That will prevent multiple complications of cerclage during pregnancy.
I don't do it. Maybe I don't. I have no experience with that.
Want to say something?
I will follow the patient and do transvaginal sonography at 11-12 weeks, and then follow the patient. And if there is need, then I will put cerclage. Otherwise, not.
Niharika, stop sharing. Yeah.
Yes, ma'am.
Can I answer?
Yes.
Yes, sir.
Mullerian anomalies are associated with congenital weakness of cervix.
Yes.
So it's the weakness of the cervix which will give up. It's not the preterm labor. So you will, one fine day, patient will come to you with os open. Okay. In this situation, your progesterone, vaginal progesterone, whether it will work or not work, I am not aware of any RCTs, but I will put a stitch after the first trimester is over, NT scan is over, dual marker is normal, put a stitch and then observe the patient as in you can. Yes, Seema, if this patient undergoes a cesarean section for some other reason, then there is a scope that you leave the stitch inside, and later date, if the patient becomes pregnant again, she can. There is no need to remove the stitch immediately post cesarean section.
Yeah. You're muted.
Dr. Kedar, do you want to say that we should not go with pre-pregnancy in cerclage? We should do it during pregnancy, but we should leave it as such?
Yeah, that's what he
Yes.
said. Yeah.
Yes.
So
We agree.
what is the harm of putting it beforehand? That's what I wanted to know.
Why do it? At times it may work quite better. At times it may not require it also.
Actually, in this case, this is a complete septum with a cervical involvement. In Niharika's case,
Yes,
with
ma'am.
a vaginal involvement as well.
Exactly.
So this is a really tricky case where there is a cervical involvement as well. In this case, maybe interval stitch, like you're talking about, could work better. But normally, this is a rare case. Normally, it's the cervix is not involved, and the septum occupies only the upper 2/3 of the cavity. And in those cases, the cerclage can wait when the patient gets pregnant. That is my take on it.
So, ma'am, when I studied this case, so there were two studies on this. One was in 2014 and one was in 2017. And both did say either you do a stitch while operating or you do a stitch just before planning pregnancy. Like some of people do wait for 3 months.
Yeah.
And so, but they all did say that you should do it before she gets pregnant.
Because of a cervical involvement, Niharika?
Yes.
Yeah.
Because
I
of
would
cervical
agree.
involvement.
Yeah. I would agree with that.
So here we are finished with the uterine septum. It was a very interesting case which Niharika has presented. And let us
Thank you, Niharika.
Thank you.
all our expert panelists' opinion was that septum usually causes abortion than subfertility. Patients having septum, they can conceive on their own, and most of these Mullerian anomalies, they cause preterm labor, so you have to keep a watch on that. And whenever required, you should not be hesitating in cutting it. So that is the take home message, I think. And once you have cut the septum, please keep the patient on estradiol at least for 6 to 8 weeks and refrain from pregnancy. But if she gets pregnant, don't terminate it. So that is our second case. With that, we are moving towards our third case, which is going to be presented by Dr. Kavita Agrawal. She is a senior IVF and infertility specialist from Allahabad. Over to you, Kavita.
Hi. Are you getting me?
Yes, ma'am.
Yes.
Yeah. Hello, everyone. It's my pleasure to be here with you all. And my case is very simple, and I think this is very common case. As an infertility specialist, you all must be getting this every day-to-day practice. The case is a 32-year-old female, married 5 years back, came to infertility.
Share screens, share screen.
I'm sharing the screen.
We can't see your case, Kavita. We can't see your case, yeah.
Just a minute.
Done.
Now you are able to see?
Not the case, only your
screen.
Your desktop.
Your desktop or your computer screen.
Beta, इसके case दिखा दो. Now you are able to see?
No.
Previously we were getting. Previously your CV we were getting.
Now it's okay.
Ideally, you need to come out of it, and then you have to open your case in the backdrop, and then you have to go with the sharing of screen.
Kavita, and meanwhile, you can just start.
Just speak here.
Yeah. Like the case is a 32-year-old female, married 5 years back, came to infertility OPD for treatment. She was obese and quite worried for her facial hair, acne, and delayed scanty menstrual cycles. She went to a gynecologist for infertility treatment. Her previous reports showed she was treated with clomiphene citrate 150 mg from day 3 to day 7 for 3 months. Husband's semen report was normal. Follicular monitoring report showed anovulation. Now, my question is, first question, she was very much worried for her facial hair, obesity, acne. How will you manage anovulation? Next is, what you will do for anovulation and her facial hair, weight gain, what you will do?
Yeah.
How will you proceed?
First of all, I will try to one thing is reduce the weight. Hello?
Yeah. Yes.
Yeah, first I will say to reduce the weight and change the lifestyle. The diet should be less of carbohydrate and more of the proteins. The maximum calorie should be 1,500. That should be the way of this thing, and increase the exercise. Then if she is very keen about the hirsutism, then we can give the this OCT containing cyproterine acetate or levonorgestrel. With we can give spironolactone also, and we can advise her for this one laser therapy and other therapies. That is the thing.
What you will do for anovulation?
You have to investigate her also, Dr. Rajul. You have to investigate her also and see her hormonal profile. And you have to see her.
Patient. She must be having high LH.
But you have to investigate. According to me, you have to investigate her. And if you can know her testosterone levels as well and free testosterone, if it's possible, definitely it will throw some light.
Level is very difficult. Sometimes the report is not reliable. And by taking one sample, you can't do the testosterone level.
Can
so you have to take serial sample.
Stop you guys here. Please take this case as a polycystic ovarian syndrome who's having CC non-response. And let's go ahead from here because we don't have time. We have 8 to 9 minutes left for this case. So please don't go into PCOS detail. We are dealing with a CC non-responder, and let's go ahead. How are we going to manage? What should be done next?
So we will go for a letrozole therapy. If he is not responding with the CC, we can give with the letrozole, or we can give the adjuvant like metformin, ionositol, like this thing. We can give also capgolian, or we can give dexamethasone also, and we can give the gonadotropin if she is not responding with the letrozole. That is my way.
Yeah, Dr. Rakhi, do you agree that this patient is a CC non-responder? And as she is telling, she is most likely CC resistance. So I would just like the expert panelists to differentiate between CC resistance and CC failure for the audience benefit. And Kavita, please stop sharing the screen.
Okay.
Since this case, she has been stimulated for 3 cycles with CC and she did not ovulate. Documentation is there. And then we need to move ahead at least now on. And presuming that the things were done all rightly done till now. Moving ahead, she should be given letrozole. And if suppose we add on little amount of gonadotropin, that always gives a better chance for these patients. Because it increases the chance of conception also. The conception rate also increases. Even we are going in for IUI or the natural cycle or whatever cycle we are doing it, it definitely gives a little edge above a response better. So little amount of gonadotropins always added would be better for these cases along with letrozole.
So, I think even you can go for only a gonadotropin cycle, because sometimes the response might not be there even with letrozole gonadotropin combination. So pure gonadotropins would give you a better response.
Just add on little to the budget of the patient. Only thing is that. So I would suggest that little amount of letrozole added to it would be definitely, since we are not planning this patient for IVF, we are planning this patient for an IUI treatment or a natural cycle. So we are not looking at a big abundant amount of the follicle recruitment and the follicle maturity.
Yes, absolutely.
Follicles. So I think little amount of letrozole added.
Little amount means what, Rakhi? Little amount means how much?
Little amount means 2.5 milligram or 5 milligram at the maximum for 5 days if you add, and 2 or 3 day doses of gonadotropins given to this patient would definitely would have good results.
I just want to ask the expert panelists that what are the criteria which you are going to take into consideration before deciding any modality of treatment. As for CC resistance cases and looking at her age and everything, what are various modalities? I would like you to enumerate it, and then how are you going to decide whether you are going for letrozole, you are going with gonadotropin or something else.
And she is 32 years. And married since 5 years.
5 years.
So I will advise her to go for at least IUI for fair chance to give at least 2 to 3 cycle of IUI. And for, as Rakhi has already said, that letrozole with little bit of 2 or 3 ampules of the gonadotropin will really can work good for her. I think so.
It just depends on the response. If she responds to this combination, well and good. I mean, your follicular monitoring will dictate whether she's really responding or not. We can't assume, but she can respond. She's obese patient. Actually, these obese patients are the ones who really pose a problem, are a real difficult PCOS to solve. And they pose a real problem.
Yeah, as this patient is obese and 32 years old, so at the same time, you will counsel her for the lifestyle modification. And if she is ready to take some time, then we can give 1 or 2 cycles of OCPs also, because she is hirsute and she must be an hyperandrogenic. We can add even metformin also if we see the signs of hyperinsulinemia, and then we start with the stimulation. And it will depend how early she wants the pregnancy or how much she is in hurry, and we have to see whether it will be good to give letrozole or start with gonadotropin stimulation. So if we are planning for IUI, then it would be better that first we give letrozole along with 2 or 3 ampules of gonadotropin in the mid or late follicular phase, and then do IUI. Or if we are straight away planning for IVF, then starting with gonadotropin will be better in that case. So for IUI, I will start with letrozole first. And if it doesn't succeed in having ovulation, then I can go for gonadotropin.
Your gonadotropin cycle. Yes, Dr. Kedar, you want
Also matters what BMI this patient has been having. If the BMI is high, we need to look at it with all the lifestyle modification as madam has told. The LH level of this patient matters a lot. If the LH is quite high enough, then also we need to readjust and
bring it down.
by OCPs.
Yeah, very true. That's true.
Dr. Kedar wanted to tell something. Unmute yourself, Kedar.
Unmute.
Kavita,
Yes.
this patient is having irregular period from the time she got married.
No, she gained weight after marriage. She put on lots of weight, around 5-10 kgs per year. She was putting on weight. That after that, she had scanty periods and irregular menstruation.
So if you look at overall, the cause of her infertility is anovulation. More or less, if that is the cause. Okay? That is one.
Anovulation.
Anovulation. PCO is anovulation.
Yes.
No ovulation. Okay? Second, I would try to, what Dr. Neela Mohori said, I would say, start her with insulin sensitizer. Choice is yours. Third, I will look at her parameters like blood pressure, and I normally look at insulin levels. And if I get post-glucose hyperinsulinemia, which I personally believe that this is the patient who is likely to go in GDM. This is my opinion. Then I will tell the patient to reduce weight, to go ahead. Because for me and for the patient, 32 or 32.6, both does not cause any problem in terms of genetic abnormality in the child.
Yes.
Waiting for 6 months will not cause so much a problem.
Yeah.
Third, letrozole works well with obese women than thin lean PCO patients.
Yes.
I would give 5 milligram day 2 to day 6 and allow her to see whether the follicle has grown or no. Once the follicle starts growing, you give her a couple of months try. If it doesn't, by the simultaneously you're losing weight. If it doesn't, if you're getting monofollicular with letrozole, like Anchu or Dr. Rakhi said, maybe add little gonadotropin to capture 2 to 3 follicles and then add up with IUI. If that also doesn't work, by the time she must have lost some weight, then I will go to Anchu and say, yes, Anchu, now we will add gonadotropin in a low dose fashion.
Yeah.
Try to get only 2 to 3 follicles
Yeah.
and do an IUI. If it doesn't, then all of you send it to me and then I'll do IVF.
What will we do? हम क्या करेंगे, Dr. Kedar?
We will send it to you, Kedar. We will send it.
I am also there for do IVF.
मन में सोच रहे होंगे, let's see. IVF भी पहले करें.
So, at the
Bias counseling.
At the same time, please clarify about CC failure and then we move ahead.
CC failure is you have given a patient clomiphene citrate. She has ovulated, documented 6 cycle of ovulation and she has not become pregnant. That is CC failure. And the most likely cause is CC induced thin endometrium, thin cervical mucus, or luteal phase defect, or something else which is not in the scope of this. So CC failure is that, and CC non-responder is you have given 150. For practical actually is 100. 100 milligram, couple of cycles, patient has not responded, you go ahead with term as clomiphene, non-responder.
I would just like to add to this that some of these PCOS have actually hyperprolactinemia as well. Yes. So we need to look into that and treat them for it, because that could also give you a very poor ovulation.
And hypothyroidism also.
Hypothyroidism also. And if the DHES level are high, then she might, do the dexamethasone. Yeah.
So,
but giving dexamethasone for obese patient would be little Anshu thoda sa.
I would prefer.
Very dicey.
If the DHES levels are high,
Never give.
Over his suit, then we can think of adrenal hyperandrogenism.
Yeah.
And then we will all send patients to Anshu only.
So, since we are talking about PCOS,
Nobody will do LOD. Nobody will do LOD.
No, I'm coming to that. Yeah. What is your view on LOD?
That's outdated.
Yeah. No, not really outdated. I won't say that.
Only
because we are doing LOD in patients in whom we have, maybe she has a tubal factor as well, and a laparoscopy is warranted.
Yes.
And in that case, if we see really polycystic ovaries looking at us, then 5 to 7 drilling points, with 5 to 7 drilling points, we can drill these ovaries without causing any decrease in our ovarian reserves and a better ovarian response probably. So LOD still has a place, though in obese patients, LOD has less of a role than in thin PCOS. There is no doubt about that.
Yes, Dr. Kedar.
If you look at LOD, the patient who has a good response is the one who is of a lower BMI, high LH, high androgens.
Yeah.
Okay. Yeah. And your diagnosis of PCO drilling would depend only on CC non-responders.
Non-responders.
Yes, CC non-responders.
And the diagnosis should be confirmed pre-operatively and not intraoperatively. I would put it up correctly. In obese PCO patient, the cause is hyperinsulinemia rather than hyperandrogenism and high LH. So the treatment wise, I think we have to differentiate correctly. And those patients who are away from medical faculty treatment, they are not being able to access the medical treatment very easily, and their thin lean PCO are the correct choice for PCO drilling, as Anshu correctly pointed out.
Oh, sorry guys, this discussion is very interesting and will keep on going. So just before we have this interesting talk, I'm just going to wrap up with few international PCOS guideline evidences for CC non-responder. As a patient who is obese, having any type of glucose intolerance, first choice, you could go for CC plus metformin. We have already discussed about letrozole and gonadotropin. Given a choice independently, the best choice is gonadotropin as per the literature. Second comes the letrozole, and then comes CC plus metformin. Studies for letrozole plus metformin are not there. That could have been a better thing, but with this, we are just winding up our cases. Now, I'm going to welcome our Secretary ISAR, Dr. Kedar Ganla, for his talk on sildenafilcitrate for OBS in gynae practice. Welcome, Dr. Kedar.
Muted. You're muted.
Okay.
Yeah.
Thank you very much for the invitation on a subject which I have worked the most. I've got almost 5 international publications on this molecule of sildenafilcitrate. We know that this drug has made a history in the field of erectile dysfunction. So phase 1 trial of this drug was for angina. Patients, the trial people who conducted the trial found that the patient was having erection. It is the first drug, FDA approved drug for erectile dysfunction, which is used in USA. Just imagine the theory of the drug used for angina. Irony is that those patients who have got angina started getting erection, and pharmaceutical companies started making money on this. So the erectile dysfunction, when we look at it, it's 10% of all ages, especially our reproductive infertility specialists will realize that little more, and especially above the age of 50, it's up to 52%. Comorbidity always should be looked into. Psychological counseling is a must. The mechanism of action is very simple. With cyclic GMP is inhibited. Release of nitric oxide releases smooth muscle relaxation, increases the blood flow, improves erectile dysfunction, endometrial thickness, and intrauterine growth patch. Now look at the busy lifestyle in today, working from home scenario today's, and this would be our future, how the babies will be made. And more, if you don't tell your patient, don't try to calculate according to the menstrual calendar. They already have an app on it, and they keep trying only on those days. Since we know now that long abstinence, just imagine somebody has got a fertile period starting on the 12th day. Gentleman will have intercourse only on the 12th day, giving all abnormal sperm because of long abstinence. So it has been found that the Viagra works only in presence of a stimulation, otherwise the Viagra will not show any work. The precaution is only that those patients who have angina or those are on glycerin, trinitrites, and those patients can have a problem with those are under alcohol and those who are going to drive after the tablets. The most commonest side effects is headache because of vasodilatation, and visual changes up to 3% is blues discoloration. So in male infertility, we all know it is used for erectile dysfunction. 1 hour prior to the intercourse, very effective for 4 hours. Drug also used in primary hypertension. Maintenance dose can be 25 to 100 milligrams. So for erectile dysfunction, it is 25 milligrams starting dose. If it doesn't work, then one can go 50 milligram 4 to 6 hours prior. But what I'm going to describe today is use of acute administration of sildenafilcitrate 2 hours prior to ejaculation in a patient with asthenospermia, not oligospermia, asthenospermia. What has been found that the baseline motility improves a lot by doing this. Now, if you look at the literature, there are a lot of in vivo studies. So what they have taken, asthenospermic sample, they have added sildenafil and checked after some time, and they found excellent motility. So this is a meta-analysis in 2017, which shows interestingly that these motile changes were observed only in infertile man, not in fertile man. So the fertile man should not think that these 100% sperms are going to be motile. No, it's not going to happen. And percentage of motility of motile sperm is going to increase. Now, how does it help me? See, if I have a patient of ICSI with count of 2 million B grade motility, I want my embryologist to be very relaxed. So I give him sildenafilcitrate 2 hours prior, take the sample and take it for ICSI. Likelihood that I will get A grade motility is very high, and that will be used by sperm sorter. Again, another function is sexual dysfunction in females. In India, very few people recommend this, come to you for the treatment and using of this particular drug. Again, the same principle, increasing the blood flow, helps in vaginal lubrication, which helps in improving the outcome. So another systemic review said 50 milligram, max 100, 1 to 2 hours prior, improves intensity of arousal, lubrication, orgasmic status. So it's a very good drug for both the sexual dysfunction. Unless the problem is psychological, this drug will not be able to help you. So increases the vaginal congestion and helps in improving the female sexual dysfunction. Another clinical problem which we come across is the thin endometrium. So thin endometrium is considered when the endometrium is less than 7 millimeter, and as we see, thinner the endometrium, lesser is the number of pregnancy. We always look at the top. I would also like to look at below. 12 to 14 and above 14 also gives you less pregnancy, but this is not the point to be discussed now. Only thin endometrium gives a less pregnancy. How do you do the measurement? About 1.5 centimeter below the fundus, vertically, longitudinal plane, and you measure the EP at mid-fundic level. And if it's less than 7 millimeter, you can try. So this is a review of literature. 3 patients with previous failed IVF with poor endometrium, sildenafilcitrate 4 times a day orally was given. They looked at pulsatility and endometrial thickness. When they combined estrogen with sildenafil, we look at the endometrial thicknesses. Excellent. Look at the PI. It fell down in both the uterine arteries. And when given with FSH, gives the best results. So it's worthwhile understanding that estrogen is required to prime the action of the sildenafil. So same thing, the endometrial thickness is more than 10 millimeters. Now, whenever you use a color Doppler ultrasound, the literature all over the world has been looking at on the day of the trigger and looking at the uterine artery. Now, when we look at ovulation and implantation, the implantation is going to happen 8 days later. And we know after the ovulation, progesterone is going to cause the endometrium compacting and the blood flow is going to reduce. So it's better that one should start doing a scan post-ovulation 7 days, and that too with the subendometrial area, because that is what is going to give you the answer where the real problem is. So this luteal phase ultrasound, the sildenafilcitrate after the IUI, can I have the video please? Can I have the first video, 35 number video please? Sishan? So I'm going to show you a luteal phase ultrasound. Can you repeat again? Hello? See luteal phase. You see the endometrium is very good. Next slide please. 36. You throw power Doppler ultrasound. Seshan. You see the blood flow is not reaching the inner zone of endometrium. And this is after giving sildenafilcitrate. So that is what the difference you see after giving sildenafilcitrate on the luteal phase endometrium. Can I have the slides please? So doing an ultrasound during luteal phase is far important. Session, I can't see my slides.
You'll have to share again.
Okay. Slides are not opening. Slideshow is not happening. Sushan? Okay, anyway, you can see the slides here now, everyone?
Yes, sir. But we can see the slides.
But why is not opening?
So we can see the slide actually. If you
We
could
can
just go
see
to
the
the
slide,
bottom.
Okay, fine, no problem. So now a patient with ART failures. So 105 ART failure, normal ovarian function, previous to IVF failure, treated with vaginal sildenafilcitrate, implantation rate improved, ongoing pregnancy rate improved, endometrial thickness came to 9 mm. The next was comparison with patient with thin endometrium, vitamin E, L-arginine, sildenafilcitrate and control. One can see sildenafilcitrate gave improved RI, improved endometrial thickness in all patients, and a relatively higher pregnancy rate as compared to anything else. Now, clomiphene citrate. Okay, we always have this clomiphene citrate issue, which has an anti-estrogenic effect, and we know that estrogen is required for arteriogenesis and angiogenesis. But adding estrogen does not replace the clomiphene receptors, because estrogen receptors are down-regulated by clomiphene. And hence, this paper talking about with clomiphene citrate, when you give sildenafil vaginal suppository, gives higher endometrial thickness and decreases the endometrial uterine artery vascularity. Another paper from these 4 groups, prior IVF failure cycle and thin endometrium helps in improving the endometrial growth and enhancing the blood flow. Now, endometrial thickness and the pattern. So, 40 patients treated with estrogen, 40 patients estrogen with sildenafilcitrate, discontinued 72 hours prior to the embryo transfer. What they found, more triple line pattern was seen. Because of the vascularity, that hazy endometrium sometimes is seen, even the progesterone is normal. This is improved by giving sildenafilcitrate and gives improved outcome in a patient with poor endometrium. Again, prospective randomized control trial, 22 patients with thin endometrium with pulsatility index on the lower side, suppository given till the day of embryo transfer. Implantation rate was higher, pregnancy rate was higher. So, what we are going to do is to show you a relevant 10 articles which showed comparative trial of sildenafil till today on thin endometrium, which showed that looking at this paper, 100 patients, 25 milligram vaginally from 8 to 12th day with E2, improved endometrial vascularity and increase in the pregnancy outcome. Observational study, normal first pregnancy, peripheral NK cells reduction. Now this is the only one paper which talked about reduction in NK cell, which according to me is little exaggeration. And the last paper, 25 milligram vaginally for 7 days versus placebo, improved pregnancy outcome with decreased endometrial cancer. Last paper, 100 women, 50 with sildenafilcitrate, 50 with estrogen. Mean ET on the SCG group were higher. Increased blood flow in patient with sildenafilcitrate. Clinical pregnancy rate higher in sildenafil group, and this was in IUI patient. So compared to sildenafil, estrogen provided better result in endometrial vascularity, marginal increase in the outcome as compared to IUI. With this, we go to another important complication, IUGR and oligohydramnios. Now I am going to talk about IUGR, which is asymmetrical. Now what is asymmetrical IUGR and symmetrical IUGR? Symmetrical IUGR is genetic origin, which is before 20-22 weeks of gestation. After that, which comes, normally we detect at 28 weeks or 30 weeks, is this where transport of nutrients from the mother to the fetus are reduced, and these because of constriction of the myometrial vessels, reduces blood flow and transportation to the kidney. So basically these vessels, syncytial trophoblastic vessels, which are constricted, leading to decreased blood flow. Mechanism of action we know, increased nitric oxide. This is the actually cause of uteroplacental insufficiency, and after giving PDF5, that sildenafilcitrate, increased nitric oxide, vasodilatation, improved blood flow, improved IUGR and oligohydramnios. This decreased arterial pressure with sildenafilcitrate and improved arterial perfusion. So what did this group did? A patient of PIH, patient of PIH came with IUGR, and they treated this patient with oral sildenafil. So oral sildenafil worked both ways. By doing vasodilatation, it controlled the hypertension and also improved the placental circulation. These are the papers which are done in vivo study. Look at the in vivo studies. In eves, rats, ovines, rabbits, lambs, they induced IUGR in the fetus, and later they treated half the patient with sildenafilcitrate and showed improvement in the parameters. The systemic meta-analysis in 2017 where 22 animal studies and 2 human randomized control trials shows increased fetal growth in fetal growth restriction and in preeclampsia and similar to the species and largest after oral and continuous administration. So sildenafilcitrate improves fetal growth and maternal blood pressure. This is from that hypertension journal regulating FGR. Now, trying to understand review of literature. Prospective non-randomized study of 50 women. First group, sildenafilcitrate, reduction in umbilical artery indices. Second, did not receive sildenafil. Statistically significant mean birth weight at delivery and neonatal admission. So try and understand why are we giving sildenafilcitrate. Uteroplacental circulation is affected. Your S/B ratio is affected. Your growth is affected. You are at 30 weeks. So you are dealing with two things simultaneously, prematurity and growth retardation. You want to overcome both. So by giving a drug which is going to increase the vascularity, increase the perfusion, increase the growth of the baby, does not allow any parameters to deteriorate. At the same time, you continue the gestational growth and try to go as much as possible to 36 weeks, which will reduce neonatal morbidity and maternal morbidity. This is the principle of the treatment. So, 54 patients, 24 weeks complicated by FGR, sildenafil versus control arm, primary outcome, 2 hours following administration of sildenafil, mean cerebral artery indices fallen down. So, your cerebral vascular sparing effect is down, pregnancy prolongation, improved gestational age at delivery, improved neonatal weight, less admission to neonatal intensive care unit with no adverse report. This is a 2018 publication. Vasodilating effect, improved uteroplacental circulation with abnormal Doppler. Now, the more talked about Strider trial, everybody is talking about Strider trial, was conducted in all these 4 places where the Canadian reported that there was a harmful effect in their babies and they reported 11 babies had a neonatal death and only in their group, and they say this study needs to be halted. Okay, so 11 babies died. In placebo group, 3 babies died. The decision of halting the trial. Now try and understand the point. This was a trial for severely dismissal IUGR, which is starting at 22 weeks onwards, not at 28 weeks. So 22 weeks onward. Finding of Dutch trial does not seem to be consistent with other Strider trial which was done in UK, New Zealand, Australia. So only Dutch reported this. Other trial did not, other center did not report this. These previous trials are almost identical. Reality check. Points to be pointed. In Indian context, do we really have a solution for 22 weeks IUGR patient? Or we concerned with 29 weeks IUGR? Where are we looking at? Are we moved ahead so much? Do we look at the financial and emotional issues of the patient? What is the gestational age of viability? In the best of neonatal center, you give the baby at 28 weeks, they will say, okay, we'll see and tell you. They don't tell you guaranteed. 100% will give the baby back to you. Pulmonary hypertension was one of the findings in those babies where the drug was used to treat pulmonary hypertension. So it's a category B drug with no teratogenic embryotoxicity effect. Now, how did they come to know? The patient with primary pulmonary hypertension on sildenafil citrate conceived. They continue sildenafil citrate throughout the pregnancy. They delivered normally, or outcome was good, and they did not find any abnormality. So there was no case of reported abnormalities. With this, we come to our patient for sildenafil citrate for growth retardation. It was published in 2016 in International Journal of Women's Healthcare. You look at the Doppler parameters showing increased S by D ratio. After giving sildenafil citrate, you see the diastolic flow appeared. Look at the endomyometrial junction. Look at the blood flow after giving sildenafil citrate. So my theory is, rather than looking at the uterine artery, why not start looking at the endomyometrial junction for looking at early onset IUGR? Another paper, sildenafil citrate for absent end diastolic umbilical artery flow, early onset. Early onset is as early as 22 to 24 weeks. We found that they had absent end diastolic flow, treated with sildenafil citrate. Patient progressed well. We continued, but we gave vaginal. We never gave oral. We always give vaginal sildenafil citrate, and then we delivered at 34 weeks. This is another paper, randomized controlled trial, which was published in 2017, not from our group. Double-blind placebo-controlled randomized trial, 37 patients in the study group, administered sildenafil citrate, TID, and control group. And what they found, increased uteroplacental perfusion, improved uterine artery Doppler, AFI, fetal weight, and overall better neonatal outcome with less neonatal mortality and morbidity. So this is the paper which talked about improvement in the AFI parameters and umbilical artery parameters. When you look at sildenafil citrate, improves uteroplacental circulation, improving the oxygenation, improving the blood flow. It will improve the fetal growth. Once the fetal blood flow improves, renal artery blood flow will improve, urine output will improve, oligohydramnios get treated. Once oligohydramnios get treated, the lung maturity gets improved, your cerebral blood flow improves, and that gives a increased window of fetal maturity, which helps in reducing the fetal morbidity and mortality. Now, only isolated oligohydramnios also has been treated in 2017, which shows improved outcome with decreased cesarean section. Because of oligohydramnios, where there is a risk of cord compression, by treating with sildenafil citrate, it helps in improving the liquor volume and helps in normal delivery and reduction in the neonatal outcome. What is important? So, what do we offer today? We offer them more empirical treatment, right? We give them so-called masala. So we give amino acid, bed rest, fluid therapy, some kind of Doppler ultrasound we keep repeating after 2 weeks, and we keep showing them the Doppler parameters are dropping down. That's all, and giving them steroids and preparing them for delivery. On the second hand, if you give sildenafil citrate, actually it helps in improving the outcome of the baby by giving us the window of growth of prematurity, at the same time improving the weight, liquor, and RDS. All three parameters are improved much better. This is something which I am very proud of. A patient of post-oocyte pickup came to us with acute pain in the abdomen on the third day of the oocyte pickup. Okay. Now, we gave her sildenafilcitrate. This was a color Doppler of the torsion showing decreased blood flow and absent blood flow in the vessels. We gave her vaginal sildenafilcitrate TDS till the time the laparoscopic surgeon should come in 6 to 8 hours. Her pain completely disappeared in 3 hours. Completely disappeared. So we repeated the Doppler and look at the improvement in the Doppler flow. So after reading the literature, what we found that when a torsion happens, okay, is first are the lymphatics, then the venous, and then the artery goes off. If you improve the blood flow, is the venous blood flow is going to improve. Once the venous blood flow improves, the torsion portion has all the toxic material which is inside is going to be drained. So even if you detork the patient, there is something called as post-torsion reperfusion injury. So by increasing the blood flow later on, you are going to cause more damage to the organ. By giving this drug, you will improve the perfusion till the time you can do the surgery. Now trust me, people have used this in testicular torsions and found great results by the time it came to us. So this was the article published in JHRS, first human study. We've done it in our group, saying that it helps in improving the outcome. So that's how it is. The sale of Viagra keeps improving in female as compared to male, and it's a drug, if used judiciously, it will give you excellent results. Thank you very much for this opportunity. Thank you.
Thank you, Dr. Kedar. It was indeed a pleasure listening to you, who's very much learned and a detailed, in-depth knowledge of sildenafil citrate, use and abuse and reuse by all the means in OBGYN, by our learned Dr. Kedar Gangla, who is the Honorary Secretary of ISAR and who has been a leading practitioner for past 25 years in IVF in Mumbai. Dr. Seema, I think you must be having some questions for our panelists, in the chats who've been asking by the delegates. Can we move on to our questions?
Welcome, Anupam.
Dr. Anupam, kindly unmute yourself.
Yeah, I was there listening to you. I was sorry, I had another Zoom meeting of the IMA Agra. I'm the member of the COVID surveillance. So I had to leave for some while. Agra has more than 1,000 cases, so we are in a very bad too, being a small city. So, but now let's get back to her. Seema, start asking questions. We are already done in short of time.
Unmute yourself, Dr. Seema.
Unmute.
Yes.
Anju wants to ask something, I think.
Yeah. I wanted to ask you that I have also used Viagra in thin endometriums. I've seen the blood supply does improve, Dr. Kedar, but the pregnancy rate marginally improved. Not too much of a difference in the pregnancy rates. That's my take. Because some of your studies also said the same, that some studies of yours have quoted a higher pregnancy rates. So what is your take? What is your personal opinion?
Endometrium, where the vascularity is an issue, endometrium, is the endometrium is going to respond to estrogen and Viagra or sildenafil citrate. Now, that is the patient who is going to respond. Now, the patient who is having some intrauterine abnormality, some Asherman somewhere or infantile uterus is not going to respond to that great extent.
Not in those, but even in these ones, I think that the definitely you can see on color Doppler the blood supply is better, as you showed in some of your presentation also, but it doesn't lead to a better pregnancy rates. Even with L-argin, I had the same experience.
If you look at the counterpart of recurrent pregnancy loss, okay?
Yeah.
What they found, if the blood flow to the endometrium on the day of implantation, if it's less, then likelihood that your pregnancy is going to continue is going to be less. Second, there are lots and lots of paper talking about in IVF also.
Yeah.
IVF failures, in FET failures, adding this drug would help to improve the outcome. Now, recently we are doing the 4th trial now, giving oral versus vaginal, and we have completed about 20 patients. Almost 80% of the patients with 3 times a day, on the 4th day they complain of severe headache, muscular aches, and pelvic congestion, back aches.
Yeah.
So that's why we discontinued and we went back to vaginal. So this is what I feel, vaginal gives the best output.
Okay.
So before I start the questions, most of the questions are on Sildenafil and CC only. So it was an excellent talk, Dr. Kedar, and knowing that you have published more than 5 international publications on the same, it becomes more pertinent. A very good thing for the youngsters who are watching as an inspiration. So the first question is on sildenafil citrate only, and question is whether it can be given to severe male factor infertility along with hypertension or not.
Not that with hypertension one has to be careful.
Question is by DPS Kamla. Can sildenafil used in male ED with moderate hypertension?
If he has an ET problem, then maybe some other drug should be looked at. Hypertension, if if the gentleman takes it, his BP will tend to fall down because of the vasodilatation effect, and then I really would not be able to answer for erectile dysfunction.
That time, tadalafil is better than sildenafil.
I think before giving it to anyone, I think his cardiovascular status has to be known.
Yes, but
and they will have to advise something about the act also, whether the man active, woman active, something needs to be done, because if you just give it and if they have alcohol on the top of it and then they just go it, these are the patients who had a massive problem with Viagra and deaths because of that. So I think one has to counsel them correctly.
I think it is best if they take a physician's consultation, and
absolutely
that would be the best. And they have to be controlled on their anti-hypertensive drugs. If it's an uncontrolled hypertension, then it's better to go back to a physician, get your hypertension control, and then come back.
So the message is that it should not be given to anyone who is having any cardiovascular disease without getting it with his physician or someone. Second question is, what is the ideal size of follicle when we can give trigger? In all patients, not alone on LU patients. Dr. Bala Abirami.
Patients on oral ovulogence, one should give it between 20 and 22, and on gonadotrophins, 18 and 20 would be the ideal.
Yeah, a little earlier with gonadotrophins.
So all the panelists, they agree that is more than 20 for oral and around 18 to 24 gonadotrophins. Right. What about two cervix? I didn't get the question. What I think Bicolis is asking about. What about two cervix? Dr. Patil is asking this question. I seriously didn't get the question.
What is asking? The septum in between the two cervix. What did they do? So I think they resected the cervix from the cervical portion. They went to the fundus.
Yes, sir.
By resecting. Is Niharika around? I think she
yes, sir. I'm here, and we did resect the cervix, and we went ahead.
In the same sitting, Niharika, or two sittings?
Same sitting, and then we did put a Foley's in it.
Okay.
Okay, so he wants to know, was it septate cervix or bicolis, isn't it?
Yeah.
Next question is
Sima, if it is a bicornuate uterus, then this is not the treatment at all.
Bicolis, sir.
Okay.
Is it absolutely necessary to put a cerclage for all or for only in those whose cervical length is less than 2.5 centimeter? Or if there is a dynamic change in the cervix, I have seen in my patients that most of them have good cervical lengths and go till term. Dr. K. Ranglakshmi.
No, I think you should do a cerclage in all patients of Mullerian defects because they have some connective tissue disorder as well. The cervix, the connective tissue in the cervix is also weak. So I think that we should not be taking a chance, even if the cervical length appears normal or in an obstetric ultrasound. You should do a cervical cerclage in patients with Mullerian defects.
Agree, ma'am. Totally agree with you.
Yeah.
And basically, when you are doing the dynamic monitoring every visit, that will be visible on that also. So that could also be the way, but that would land you up in an emergency. So it's better to go for prophylaxis, though it is very controversial. There are two school of thoughts: cerclage versus vaginal progesterone, or nothing, just expectant management.
Yeah,
Dr. Sima, let's understand that emergency cerclage is more of a failure than being success, and it requires more expertise to do that.
That's
more failure rates and more failure rates also.
And then you will repent that I wish I would have done it. You know, and this is a typical patient. Typically at 27 weeks they will deliver. So then the issue changes to neonatal morbidity and all that other soap opera.
I completely agree with you. Yes. The next question is for PCO drilling, which mode is better, coagulation or cutting? Dr. Sandhya Rani.
For PCOD drilling, it is the cutting mode which is better. Cutting, and the lowest setting, you should put the patient on the lowest setting so that you cause less damage of the surrounding tissues. And it should not be exceeding more than 5 to 7 drill holes.
So next question is your experience in using clomiphene and letrozole together in polycystic ovarian syndrome patients, resistance to either of the drugs. Dr. Isha is asking this question.
What?
Using letrozole and clomiphene together for PCOS CC non-responders. Does any of panelists have any experience with using CC plus letrozole together?
No.
If you understand the physiology of the drug, clomiphene goes and blocks the hypothalamus. Once it blocks the hypothalamus for estrogen,
no role
of letrozole, unless only the intra-ovarian androgen will increase to an extent. So try and understand, one of these kind of papers will be always published. Don't go on a single publication anytime and don't change your practice. Stick to one side. If a letrozole non-responder comes, then you try extended letrozole. So you increase the window of FSH, or step up letrozole, whereby you increase the FSH threshold above the threshold. Then you are likely to improve. Or like others said, consider combination of two. That will be much better.
So I think it's very clear that we should not mix apple with oranges. And what should be the dose of sildenafil? Nothing is written here.
It's personal use or sorry.
Always, all the phenomenon.
Start with lowest dose.
So you can revise the doses for endometrial thing and for IUGR.
The action of the drug is going to remain for 8 hours. The best thing is to do PDS. With the tablet being little soaked in the water, you have to put it inside. If you don't put the soap tablet inside, if the vaginal secretions are not good enough, the tablet will not dissolve and remain inside. To be dissolved, you have to put, because these are effervescent tablets now. So you need to put 2-3 drops of water and then put it inside. The action will be much better.
Much better.
That too also deep in vagina.
Okay. Next question is sildenafil always given vaginally for all indications? Dr. Anju Rastogi is asking. Yes, practically yes.
It's like micronized progesterone. Micronized progesterone is for vaginal use. sildenafilcitrate for women is for vaginal use. Because it is closer to the organ of delivery where you're going to have the maximum impact. Isn't it? Just imagine you take a tablet of 50 milligrams of sildenafil, your brain is also going to get 5 milligrams. Means it doesn't want. Right? So I am very clear. It's vaginal sildenafilcitrate is the best route.
So in hypertensive, any change, Dr. Kedar?
No, that is only one paper. No. In PI's patient, the new trials are coming up.
Yeah.
What is going to happen? We are going to be little bogged down. See, once you give, say, Depin,
yeah,
you know
sudden
the dose.
Scratches,
sudden. So we don't know. So you'll have to wait and watch.
Yeah.
If you get a patient of PIH with IUGR, you start off with 25 milligram orally. Because there you give vaginally, it will not have a systemic effect.
Yeah, that's why I asked.
So if you want to have a systemic effect for blood pressure as well as IUGR, then only you'll have to use orally.
So what is the role of sildenafil in oligohydramnios? Dr. Archana Goel wants to know.
I showed in the last slide, IUGR and oligohydramnios are two sides of the coin. If there is isolated oligohydramnios, first of all, you need to go back to your malformation scan and check whether there is any renal abnormality or tracheoesophageal abnormality. If there are no, by definition there is no abnormality and there is isolated oligohydramnios, there is no history of leaking PV, then sildenafilcitrate will improve the blood flow and improve the oligohydramnios, which will be beneficial.
Okay, she has just continued the question. She has presented a case of her. Is there any role of sildenafil in a patient of 26 weeks of pregnancy? Ultrasound shows fetus having bilateral multicystic dysplastic kidneys with severe oligohydramnios with reduced fetal movements.
No. This is a congenitally malformed fetus. So I don't think so. It's not going to work. Should not.
Next question is, what are the USG findings of luteinized unruptured follicle?
Yeah. It's a typical follicle with a fishnet appearance, which means the hemorrhages appear a big follicle with thick walls, fishnet appearance because of the hemorrhages inside it, no free fluid in the pouch of Douglas or around that ovary. And if you do the color Doppler, then you will find that the RI of the follicular wall or the ovarian wall is fixed at 0.5, which means poor blood supply. So these are some of the findings of a luteinized unruptured follicle, and you distinguish it from a corpus luteum because corpus luteum will have a good blood supply, whereas an LUF follicle will have a poor blood supply.
In continuation, if a patient with LUF does not ovulate with gonadotropins, what is the next step? Will you increase the dose when you decide on IVF?
No, you have to rule out the causes as we discussed, that endometriosis, PID, recurrent PID, and sometimes it's said that even NSAIDs, non-steroidal anti-inflammatory drugs, can also cause LUF. Yeah. So you have to look into where the problem is actually and solve the problem. And IVF is always, if this doesn't work, this doesn't work, this doesn't work, IVF is the only answer for IVF specialists.
Many people are asking, is sildenafil an FDA approved drug for IUGR and oligohydramnios?
No, it's not FDA approved drug. Well, it is not FDA approved drug for thin endometrium. It is not FDA approved drug. If you look at your estrogen tablets, it is not approved for using in pregnancy. But in all FET cycles, we do use it in pregnancy. So you have to look at the cause and the pros and cons of the whole thing. It will come as a FDA when American people give FDA approval to their drug, and then Indian pharmacopoeia will give. But till that time, you can't allow your patients to go like that. You have to explain and give them the trial. Look at the endomyometrial junction. I think that is the key. Endoplacental junction. Start looking normally also, 28, 32 weeks Doppler, to have a idea in your frame of mind, what is a normal flow. then you will be able to pick up IUGRs little earlier than what we are doing now.
So people are also asking, what gestation do you start the sildenafil for all these oligohydramnios patients? Is there any contraindication, and how long do you continue it?
Try and understand something. First of all is the clinical suspicion. You should have a clinical suspicion. Secondly, for all our high risk patients, everybody has a different parameter, but I have at 28 to 30 weeks, I get a power Doppler, color Doppler ultrasound. Now, in that Doppler ultrasound, if I find an abnormality, I will start the therapy and I will continue till 35 weeks where the maturity is adequate.
No, in symmetrical IUGR, Dr. Kedar.
No. Symmetrical IUGR, this will not produce very good result because the cause is genetic. Is genetic. So one should not try to do anything according to me. Symmetrical IUGR, unless you do a karyotype and all that thing, I don't think so in symmetrical IUGR you should do anything.
So with this, we have completed the plethora of questions, and I am very happy that expert panel of experts, they have answered everything very correctly, and that has might benefited our audiences, and they must have got all the answers they wanted to. And with that, I would really thanks again to Secretary Dr. Kedar Ganla, our chairperson Dr. Anupam Gupta, Dr. Rakhi Singh, Dr. Neelam Mori, Dr. Rajul Tyagi ma'am, who joined a bit late. She is a big IVF specialist from Lucknow, as we all know. Dr. Neelam Mori, she is from Varanasi. Dr. Anshu Jindal from Meerut, and Dr. Kavita Agrawal, Dr. Monica, Dr. Niharika. All of you were awesome. I am thanking all of you on behalf of Bharat Serum and TOG webinar and UP ISAR for just participating and making this panel worth attending. Thank you so much once again.
Thank you very much.
Thank you, Dr. Seema, for beautifully conducting and moderating this panel for UP ISAR.
Yes, Dr. Rakhi, please, last words from you.
Thank you, Dr. Kedar, for beautifully moderating and conducting this panel. Sir, and thanks to Dr. Kedar for nicely enumerating the whole talk on sildenafil, enlightening all of us.
UP ISAR should be more active. I think UP ISAR should really.
There's another webinar on 18th for UP ISAR, which is lined up, which is on IVF in cancer patients.
Wow. Good.
IVF in cancer patients, which is there. I thought let's have something out of the box. Normally we've been doing all the things. Let's have little different. So it is IVF in cancer patients. Let's move ahead and then looking for more webinars. I would like to address one and all everybody that kindly whenever we are doing any webinar, take UP ISAR as the point and then move ahead in your webinars. Always join hands with UP ISAR and do it.
I think it's a very nice initiative, Rakhi, from UP ISAR, that 3 interesting cases to be initially for a discussion followed by a presentation which gives you a little more impact, and the seniors also are involved in decision making of a tricky case. Excellent. Thank you very much once again. Anupam, thank you so much. Thank you everyone for inviting me.
Thank you, Kedar, for being with us. Thanks all the panelists. Thank you, Seema, for wonderful moderation, and Rakhi, the dynamic secretary, for organizing everything. Thank you so much. Thank you, everyone.
Bye.
Thanks a lot to Bharat Serum and the TOG Science Integra for organizing. Thank you. Bye-bye.
Thank you.
Again on the 18th. All of you should be there on the 18th for the next webinar.
Yes.
Yeah. Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.